and then. Okay, so I will officially welcome you all to this webinar. While we wait for Elisabeth White from Doctors of BC. This is the first webinar in a series of webinars which we'll be organizing to talk about maybe some different ways of practicing, of options of practicing. We are very pleased to have Dr. Erin Hasinoff here and Dr. Lisa. How do you pronounce your last name? Gaede?
It's Gaede.
Gaede, yeah. Here to talk about their experience, how it was for them to move to a group practice. And I see Elisabeth just signed on. Welcome, Elisabeth. We will have 1.5 hours together. If we're done sooner, we're done sooner. But we've asked Elisabeth to start off with some general information about a group practice, a group contract, and then asked Erin and Lisa to really talk about their experience, how it is for them when they moved over about a year ago. So we will do it slightly informal, formal, informal. So if you have questions and you can't really wait, just raise your hand and we see if we can fit it in. But otherwise, please just type it into the chat box. I will monitor the chat box for when the presentations are there. I also collected quite a few questions already in advance. So some physicians might not be able to attend today. So then I will make sure that those questions are answered. We will not go later than 6:30. Just before that, I will give you a bit of a heads up that the time is up. And I also want to let you guys already know what kind of webinars are coming up in the future. So with that, I would like to first ask Elisabeth, Erin, and Lisa to introduce themselves briefly, and then I will hand it over to Elisabeth for a presentation. Elisabeth.
I'm Elisabeth White. I'm the Senior Regional Advocate and Advisor for all physicians in the Vancouver Coastal Region.
And my name's Erin Hasinoff. I'm a family physician in North Vancouver. I work in a practice with Lisa, and we'll tell you a little bit about our experience going over to the GP group contract starting in August of last year. I do longitudinal family practice, work in the office 3 days a week, spend a lot of my free time working other than that, which I'm sure is familiar. And otherwise, I have 2 boys in high school and love living on the North Shore. Lisa?
Yeah, and my name's Lisa Gaede. I work in a practice with Erin. We have a fairly large group practice, so there's about 11 of us total in our office space, and we'll talk a little bit about that. I also have a practice. I'm in the office as well 3 days a week, yeah, love living here in North Vancouver.
Great, over to you, Elisabeth, to kick us off.
Thank you, and I'm glad to see that David made it back to Powell River. I saw him yesterday afternoon at the office, so I'm glad to hear that you landed correctly. So I will share my screen and open this up. Okay, so I guess I want to start off by saying that when Kirsten originally asked me to do this presentation last spring, I kind of assumed that by now we would have a new solution and I'd be presenting on something totally different. So I want to start the presentation by saying that these group practice contracts are a current available solution, but at Doctors of BC, we support a plurality of payment methods and are in active conversations to have better options than the group practice contract and alternative options. So I'll let you know what's available now, but I want to start off by saying that. So my role, for those of you that don't know me at Doctors of BC, is to advocate, inform, and connect. So I help with physician discipline cases, usually within the health authority. If a nurse makes a respectful workplace complaint against a physician, or they're having problems with their department head, I help physicians through those processes. I also work under the Memorandum of Agreement on Physician Physical and Psychological Safety. I work on a local, regional, and provincial level. Can answer PMA questions to the best of my ability. My director, Rob Hulick, is directly involved in the negotiations, and my role is fully funded by physician dues. I'm under the Economics, Advocacy, and Negotiations Department. We do contract reviews. I present the Health Authority Engagement Survey, and I can tell you about Doctors BC initiatives. I can connect you to MSP, WorkSafe issues. We provide negotiation support, the Physician Health Program, audit and billing. Okay, so a basic overview of what the current group practice contract offering is I want to start off by saying that these are Ministry of Health contracts. They're not ones that we negotiated. They were created to test the market to see if there would be uptake for physicians to work under an alternative payment plan. So, and the ministry is within its right to create contracts that are PMA compliant. But at the time that these were released, we had a few questions. But we weren't in direct negotiations with the release of these contracts or the new to practice contract. So the 2022 rate for the contract is what the greater of 295,000 per year, or up to a maximum of 336. You also get, you can bill for QI, which is complicated, but it's, the rate was increased to 20,400. It's a 3-year duration of a contract, but it has the option of terminating with 6 months notice. There's a 1,680 hours requirement, and it must include a physician group of at least 3 physicians that all use the same EMR. I was involved in some situations where someone was on a different version and they weren't able to get a contract together. So just to go through what the current contract process is that a physician group gets together and they decide that, hey, this contract seems right for me, and they submit an EOI, an expression of interest. The ministry assesses the EOI, they look at every physician in that group, they look at all of their MSP billings, and they provide a total dollar figure for a contract. They say, okay, this group gets $1 million based off of your billings. So then the group decides, okay, are we okay with this financial offer? Is $1 million fair for us? And the ministry then, and if they agree, it moves forward. So if you're interested in just kind of seeing what you'd be offered, you can submit an EOI and see what happens. So then if you're interested in moving forward, the Health Authority Medical Affairs presents the group with the contract with the number amount filled in. The physician group then connects with Doctors of BC negotiations to review the contract just to make sure that it actually follows the template. And then you also should hire a lawyer to write a group governance agreement. So then the physician group signs the contract with the health authority. So it's a VCH contract. This doesn't make you a VCH employee, but you're contracted under VCH. And then care is provided to patients under the contract, and it's tracked through Teleplan. And then a year later, the Ministry of Health analyzes the data and then provides a panel adjustment and says, okay, you should be seeing this many patients, and this is the new amount of money that you'll be getting based off of what you did last year. So it's kind of a very robust process that involves a lot of different bureaucratic agencies. So the support that we can provide at Doctors of BC, if you're interested in going in one of these contracts, is my team is, we can answer group and individual specific questions about the contract. What does this clause mean for me? We can walk you through the contract application process and kind of keep the ball rolling. I actually assisted with Dr. Gaede's contract. It was a long process because you were pretty early on in the, but you started before there was a process. Then the negotiations team, they can help you understand the terms of the contract. They'll outline any kind of concerns or issues. They can be involved in direct discussions with the health authority. But just to highlight that there's not many negotiable areas of the contract. It's pretty much standard, follows a standard format. So there isn't need for deep negotiation support, but they'll just make sure that that standard is upheld. Then the practice support program is involved in providing planning panel cleanup, and then all of the QI activities under the contract are through PSP. You can't just decide to do your own QI. It has to go through the practice support program in order to qualify for that $20,000 a year bonus. So just a little bit of an overview on what a group governance agreement is. We really recommend, and it's a requirement to signing the contract, that there is a group governance agreement. And this essentially is the group practice contract is a contract between you and VCH, but the group governance agreement is really deciding how you want to work together. How should you divide up the payments? Okay, if someone wants to leave the group, what happens? How do we vote on making changes? It puts everything in writing, so that it's fair and equitable, and you're relying on that contract rather than potentially ruining relationships between your colleagues. So because every practice is so different, we don't have a group governance agreement template. So you'll have to contract your own lawyer to draft something that's really specific to your group, which is one of the barriers of going on to the contract. So just to get into some of the barriers before is the group governance agreement. It's a very bureaucratic process involving the Ministry of Health and the Health Authority. I've seen kind of an inconsistent application of the contract requirements. One group will be told yes, and then another group will be told no for the same reason. And that's been frustrating for me for trying to answer what the contract requirements are. There's a pretty high reporting burden, and I think Lisa and Erin will get into that more than I can, but it's just a different reporting burden essentially. There's also, you're signing a contract, and then there's uncertainty about what the value of the contract is in the next year. Also, the contract has to have PCN alignment, so you need to be a group that is wants to be aligned in PCN activities. And physicians that are on the contract find that it has cumbersome QI requirements. So what's next? Currently, there's only 11 groups covering 50 physicians that are on the group practice contract provincially. And really, this contract was created to test the market. And in my opinion, that test failed. So I think the contract works well for some people and has been good, but I don't think that it's a robust enough solution for everyone. So the PMA is expected to be ratified this fall. One of the good things is that the new to practice contract sets a really good baseline for a better contract solution. I have mixed feelings about this because I want to make sure things are equitable between members, but the new to practice contract kind of has like a rising tide lifts all boats mentality. So whatever the next solution is, it needs to be better than the new to practice contract, because as it is now, sometimes the new to practice physician will be the highest paid physician in the practice. And then there's been a mutual recognition between the ministry that this contract is too complicated and difficult to get onto, and that whatever solution comes next needs to be really simple. Doctors of BC supports a plurality of payment methods. Fee for service is never going to go away. We want physicians to get paid in the way that works best for them and is not cumbersome, that's simple, good for patients, good for doctors. And so I'm happy to answer any questions about this, but I'll let Lisa and Erin, or I'll answer any existing questions, and then we'll hand it over to Lisa and Erin, who might go into more about their specific experience. Thank you.
Thanks, Elisabeth. You mentioned that the sum is determined from the previous MSP billing. Is there any factoring of intensity of the patients and for instance, yes. Okay.
So it's a complicated formula that uses the ICD-9 codes, but the ICD-9 codes are very underfilled because there's no remuneration associated with saying like your patient's has diabetes and this and this. So the formula kind of ends up being, the way that that's calculated isn't actually as representative as I think it should be. That's the answer.
Thanks, Elisabeth. Any other questions for Elisabeth at the moment?
I have a question. So what if you want to go on the contract and then you decide that this doesn't work for me? So what is the minimum time commitment? And then the other thing is that if we are a group in the clinic and then some doctors want to go on the contract and some other doctors don't want to be on that contract, is that possible? Because kind of I hear that it has to be kind of the whole group, so I'm not sure.
I think that's the perfect segue into Dr. Gaede and Lisa and Erin starting off, because they have a unique practice arrangement that will answer that question more robustly than I could right now.
Sure, yeah, I can jump in and tell you what our experience is, but this is, I think, one of the areas, as Elisabeth pointed out, that is inconsistently applied. So our group is a bit of an odd group because within our group, we sort of have two different EMRs. So we sort of have a group on one EMR, a group on another EMR. And so for our contract, it does include only a subpart of our group on a single EMR. So we still do have groups or physicians in our group billing fee for service. But they allowed it because of the way that our practices are completely differentiated by being on different EMRs.
So this might be a good moment for you guys to start your presentation, and because you might answer some of the questions that others might have. Yeah. And Elisabeth will hear on the call the whole time. So if at the end we have still questions for Elisabeth, we can always direct them to her.
Okay, so I'm just gonna put my share screen on. Hopefully it'll work properly. I think I have to do that slideshow thing, don't I?
Yes.
Perfect. And I think, Erin, you're going first. So I probably need to figure out how to click to the next one. There we go.
Perfect. Excellent. So yeah, actually, this is a good place to start. We were just talking about this. So we should update this a little bit because we are a group of 10 of us who work together, but we actually now have 2 contracts active in our office. We were the first to go on this. Ours started in August 1st of 2021. And then 4 of our colleagues joined a separate contract. I think they started in October of this year, and we run things completely separately. We have separate group governance agreements, and it was a slightly different process for them, even going through a few months after what we had done, just because there was a little bit more structure to it by that time. We are on Profile, we're on IntraHealth, and they are on Accuro. We also have a couple of physicians who didn't want to join a contract at our office. That was a bit of a sticking point right from the start because they wanted to stay on fee for service. But once the ministry realized we have separate databases, so they want to keep the patients separate. They just don't want it to happen that our patient who is attached to us on a contract might then go see Dr. X down the hall to get some sutures done or something that might be a higher billing service. So that's just something you'd have to be careful of. And we can't say for certain that they would actually accept you going ahead and doing a mixed model like what we have, but they did in our office, which was great. So that's the beginning of how we started. So we all work in North Vancouver, and the reasons we were interested in going towards this, we were all a little bit fed up with fee for service and how uncertain it was financially. We just wanted the stability of knowing that we would have a monthly payment, that, you know, whether you're off for a little bit, or if you were injured or someone else is covering you, you're still going to get the monthly amount. You just have to then divide up how it's going to be paid out. We were hoping, because we do teach in the UBC residency program, that it would be more attractive to new grads, making family practice more sustainable. We were interested in working with the PCN, which is getting going in our community. So currently there's mental health clinicians, there's pharmacists available, and there's a nurse in practice that's available in our community. And then we thought, well, we're willing to be early on this process and just see what it's all about, and learned a lot along the way. Next slide. So we felt a little bit like this when we first looked at the contracts. We found it really difficult to sort of figure out what was going on. We put our expression of interest in as soon as it opened in November 2020. We didn't actually get our contract going until 9 months later. And part of that was we just didn't know where to turn to get help with understanding the contract, how to set up a group governance agreement. There really wasn't any framework for that yet. So we kept thinking that we were just a little bit lost in what the process was about. We'll walk through a few of the next steps, but this was just an idea of like how it took a long time for us. Next slide. So I think Elisabeth touched on this. Essentially, you do need a group of 3 who at least work together on the same EMR. When the expression of interest really just does that, the ministry assesses how much they feel like they're going to offer you to begin with. Interestingly for us, it didn't have to do with our panel sizes, even though we had that pretty up to date from doing panel management. It just had to do with a segment of 2019 billings. And then they just said, well, if you build over a certain amount, we'll offer you 1 full-time. If you're under a certain amount, we're going to offer you 0.5 of an FTE. And that's just their starting point. And there really wasn't much to negotiate there. In the end, we said, okay, between the 4 of us, the 3.0 FTE seems reasonable as a starting place. So that's where we started. The group governance had a lot to it, and we eventually went to a tax lawyer to help us with that, just because all of a sudden you're getting shared income, which we had never had before. So you needed a group bank account. You're no longer paid individually. So the total amount that's coming to the doctors in your group comes in once a month to all of you together. So it's pretty important that you have a lot of trust in your colleagues that you're going into this with, and that you have a really solid group governance, because it is your whole income that's going through that. And then as mentioned, just Doctors of BC did help review the contract before we signed it, which was great because they actually realized that we were signing a contract that had a lower amount because it was previously offered at a lower amount. And they said, oh, hey guys, did you know that's updated? So you should be getting paid more. Next slide. You saw this already in Elisabeth's presentation, just the sort of components that have to go into the group governance. And luckily the lawyer we worked with just sort of walked us through those steps. Other things to think about before you would sign a contract, you actually do need a new group payee number for Teleplan for billing. And so that has to get set up with Health Insurance BC. And also then you are going to need a bank that will have a joint account. So your payments will come into that, and then you'll be dividing that up between you however you see fit. Next slide. And one other big lesson that we learned was don't forget to make sure your EMR is ready for this process. That was something that we learned sort of in retrospect, because they already had the new codes for what we'll talk about later, like encounter and shift coding, but nobody had actually gotten it set up so that when we submitted things, that it would go to the correct payee number. And it was quite, there was quite a bit to do with our EMR vendor after the fact. So also, there's a process, because you are still billing some things fee for service. Your WCB and your ICBC do not go under the contract, so that you still do need to have your own personal payee number. You have to have your EMR be able to link with that personal payee number, because unless you want it to go into your group payee number, but then you have to sort out whose payments those were. We also have locums that come in and work fee for service in our offices, so we still needed to have fee for service billing available within the EMR. So you couldn't just set every default to just be the new contract payee number under $0 billings. Next slide. And I will pass over to Lisa, just with the idea that, we were sort of hoping that this would get us out from under all of the paperwork we have to do, but there is sort of just a new set that you're doing with this contract.
Yeah, thanks, Erin. Okay, so I thought I would just talk a little bit about what changes sort of in our day-to-day life and our practice. So, whoa, what did I do? Oh, okay, I guess my mouse changes that. Sorry about that. So we have to track our hours and sort of basically the general categories for the type of work that we do on a spreadsheet. And it sort of has direct patient care, indirect patient care, quality improvement, administration. This is burdensome. And I feel like the administrators should have to track their life in 15-minute increments for a few weeks before suggesting that this is a good idea. But we'll just show you that's a workflow thing that is different for us. And then instead of billing fee-for-service codes, we still have to sort of bill what is called encounter codes in our EMR, which are much simpler. Like there's only 21 different encounter codes, so that's a lot easier to learn them. And then we also have to bill something called shift codes, which is a bit of a pain, which is basically like clocking in and clocking out for your job. We submit the information. Actually, Erin does this for us. The information on our hours worked have to be submitted to the health authority on a quarterly basis. And the other thing that we have to do is attach our patients to our practices. And basically that you're supposed to have a conversation with the patients to make sure that they agree with attachment. And then basically you have to bill a code that shows that that patient is attached to your practice for that year. And because we're in the second year now, we have to do it all over again, which is really frustrating because in a longitudinal practice, you know, it's not like our patients are going anywhere and the poor patients are a bit confused. They're like, are you not going to be my doctor anymore? Like, I don't really understand, you know, what's going on. So that's a bit bulky. So just so you know, this is what our hours reporting spreadsheet looks like. So the good thing, you can see, like I can click management and coordination of patient care, sorry, paper. So I like that because it does actually value our administrative and charting time. We can include that in the hours that were worked. And then it does ask us to track separately our actual visits and procedures, quality improvement, multidisciplinary team coordination and planning. So we have to fill this in every day. So it took a little bit of learning. There's new language. So we learned about shift codes where we basically have to put in the time we started each day and the time we finished each day. And we have to calculate how many 15-minute increments that is and put a number in there. So like if you worked 10 hours, you'd have to write 40 in your shift code. So 40 15-minute intervals. Encounter codes I talked about already. You still do bill your ICD-9 codes. So just like you would when you're billing fee for service, except for the difference is now I'm much more careful to bill multiple ICD-9 codes for my patients that I see for more than one problem, because that does factor into the complexity calculation that they use to determine your payment. And then I already talked about the attachment codes. So you have to learn this new language about all these different codes. These are the encounter codes. A couple are missing from here, but these are the main ones. So, but you can kind of see like a 97512 is an in-office visit. A 97517 is a telehealth visit. And you know, that's like our 0100 of billing. You know, those are the two codes that we bill most often. Are we switching here, Erin? Yeah.
Yes, sorry, I was just having some trouble with my mute. And actually just one thing to mention though, is that short list of codes that Lisa just had up, it really is simpler. Like there's no age codes, there's nothing, it doesn't matter which immunization you gave, you put in one immunization code. So if you see somebody and they happen to be in for a visit, plus you give them an immunization, plus maybe you've done their pap test that day, you end up just billing all three of those things, but it's pretty simple and you're not worrying about any of the age codes or having to bill half codes or anything like that. You just can insert those three different things that you did for that day. We have found it simpler. So just wanted to talk a little bit about where we're at. We finished year one of our contract. We're sort of waiting to have our first meeting with VCH about our year one and sort of where we're going for year two. They've assessed our panel sizes and are sort of telling us what band we fit in the contract, because we all look after more patients than what was kind of expected for our FTE equivalent. So we're being told that we'll be getting more as our monthly payments and as our annual payment. We just wanted to tell you a little bit about the benefits we found so far, and then Lisa will talk a little bit about a lot about the challenges, and then we're happy to answer some questions as well. I think probably one of the biggest benefits we found is feeling more fairly valued for all the actual work that we all put into our practices. The fact that we are actually charting and adding to our shift time, all of the indirect patient care that you do really does make a difference. So when you're sitting there after your last patient leaves and you're doing a couple of hours of work or doing that in the evening or on the weekend, that's now actually being considered part of your job. So it really just changed our framework of feeling like somebody recognizes that this is part of my work. And so that has really helped. We have found that it's really been nice to take away worrying about looking after a complicated person or somebody's come in needing more of your time, from worrying about whether that's a billable service, so that you just can give more time. We will sometimes also shift our schedules, so we know somebody's coming in, maybe they're coming from further, or they have a few things going on, so you know you're going to need extra time. You book them for half an hour, but you're no longer sitting there thinking, oh my gosh, I'm dealing with their 3 issues and I have the waiting room filling up. You can actually start to adjust your time and your bookings a little bit. It doesn't mean we can take lots of time with everybody, because we just wouldn't get through our days and the volume that's needed, but it does just mean that for those complicated factors, you don't have that little voice in the back of your mind saying, how am I going to bill for this? What am I going to do with that extra 45 minutes I just spent? It's all considered part of your hours. Other benefits that just to know is that contract really just covers your in-office family practice time. So if you're doing any uninsured services, any long-term care, any maternity, that comes to you directly. You can still be doing fee-for-service for your maternity and long-term care. All the third-party billings, you still bill directly. So this is not one of those alternate payment models where you're signing over all of your alternate payment. If you're doing insurance forms, if you're doing WorkSafe, ICBC, any of that is still coming to you directly. So it's outside of the contract. You just can't include that in your hours. So you have to sort of put that on your excluded time if it was within your shift time. And otherwise, we usually just stop it, say, okay, I took the break for an hour because I was doing something different that was not contract time, and then put it back, put in another segment on our hours list. The administration of just sort of joining and being part of the PCN, that can be covered. So initially when we were meeting with a mental health clinician to join our team, we were able to bill for the time of the hours that we were spending meeting with her and getting that process started. We've also liked having the PCN support. It is not exclusive to people who are on contract, but we were able to get that started. And our other group in our office, we have a mental health clinician working with us. They have a nurse in practice working with them. I've had some experience with that. Another thing to highlight is that locums can actually bill fee for service still to look after patients in your practice. Where this is helpful is they underestimate how many hours a full-time physician would work in a year or in a week or in a month. So when we've gone away on holiday, instead of having our locums use some of our contract hours and then having to pay them out of our income for that month, they can actually see our patients, then they can bill fee for service. We can, give them their percentage, and then we can have the help with the overhead coverage for the time that we were away. So you still can maintain your hours. On the other hand, if you're worried about not making your hours equivalent for the month, you can then just have your locum cover on contract. We've done both, but it has been a real advantage just to try to save those contract hours, because we're all working more than what was allotted to us. And I think the other huge benefit we found is it's just really nice to have stable income. We know exactly how much we're going to make in a month. It helps when our overhead costs come in each month. We know that it wasn't variable depending on how many people we saw, or did we get billing rejections. It's just you get your payment. And that first month that we got a payment at the end of the month, we were just like, wow, this is amazing. It just kind of came through, and it's been nice and steady. One of our colleagues got injured, and she was going to be off for a couple of months, and so for her it really helped to know that there was some stable income. She still had to pay her locums who were working under her contract, but she knew she could cover her overhead. She knew she wasn't going to be have absolutely nothing coming in during that time. So that's been really helpful. I think that's all I have to say right now. Oh, and I guess I would just focus on, for me, not having to look at MSP rejections anymore has been huge. It was always such a heart sink to spend so much time with counseling visits, and then those would be the ones that seem to always get rejected. And you'd be trying to rebill and fight back about why this was not paid, and some of them never got covered. And I just love that there's barely anything in the reconciliations anymore, unless we've done a shift code wrong and it bounces back because we forgot to put our number of units in or something. It's very brief. You don't have to worry about it. You're getting paid based on your time, no longer on whether you got your building code rejected. So I'll pass over to Lisa, and we're happy to answer some questions afterwards, because there may be other things you guys want to know about for benefits of being on this.
Yeah, perfect. Yeah, so I'll summarize some of the challenges, and then we'll be pretty much done, and then, you know, open for questions. So some of the challenges we found is that the contracts, although they're offered through the Ministry of Health, like, we found it very difficult, and it still is very difficult to communicate with them, especially at the beginning when we had lots of questions, we didn't understand the process. So basically the contact at the MOH seems to be an email address. It's sort of the only way you can ask questions for the most part. And they're quite variable in the timing that they take to respond. So it's sort of shifted where they've changed so that your health authority is your main contact. And so we're supposed to contact the health authority, who then will contact the ministry if needed. And through our year on it, our initial contact, who was Sneha, has now changed to Sandy. And, you know, it's just different, right? They're just sort of different people. But they are generally quite responsive, I would say. So that's actually been a helpful thing to know that that's our go-to person. We already touched on the EMR challenges, but I will say, like, this continues to be an ongoing problem for us, even a year or so into it. Probably because, as Elisabeth said, there's only maybe 11 groups on there. Our vendor was not particularly motivated, you know, to make changes. So most of the things that we're doing were sort of little workarounds created from the way that their program was set up. So it has continued to be challenging for us. In particular, our WorkSafe billings still don't seem to work properly, and other things like that. The reporting requirements, we've already touched on that. It's a bit onerous to both have to chart every 15 minutes that you're doing, and then also shift code, click in, click out. That part does make me feel a little bit totally untrusted. I have to like double report that I'm actually working. But the nice thing about doing it is actually we can look back and reflect, and we can actually see how much we are working, right? Which is, I think, actually quite interesting. The QI requirements, they are a bit bulky. There is some specific things that you have to do. And again, just as being new adopters, everyone was trying to figure out what that was. And so we were kind of caught in the challenges with not really knowing. And then the attachment continues to be a bit bulky. The main thing is that the contract estimates 1680 hours for a full-time equivalent. And we really feel that that really is underestimating the amount of hours that physicians work. The finances, so there is uncertainty sort of about future payments. Now that we're in the second year, it's actually worked out okay, because our payment will go up based on our bandwidth or band level or whatever that we've been assessed at. Because again, we're providing sort of more care than our fee-for-service billings, you know, sort of suggested. But one of the things that isn't clear is that there's, other than the band change right now, there's no lift. Like, so even maybe that'll come with the PMA, that there's actually an increase, you know, year to year. But there is that uncertainty about what's going to happen in the next year. Panel changes or group changes, again, this is a little bit less clear. So if, for example, we wanted to work more, like say I wanted to pick up an extra day a week or something like that, I couldn't just decide to do that. I would have to get approval from the health authority, and there'd have to be an agreement to change the panel for the funding to change. I guess I could do it, but there just would be no increased funding for it. And then also for group changes, we haven't tried this yet, but again, if you want to add someone to your contract, again, you have to have the health authority involved and approve it. We don't really think they would not, but again, it's just a little bit of loss of autonomy there that we can't make that decision sort of on our own. And then the other thing we noticed is, although we're not health authority employees, the health authority is trying to understand what exactly we are. So like one day we got an email saying, we need everyone's COVID vaccination status, by this evening, or you won't be able to see patients anymore. Like, so they sometimes just do that and you're kind of like, okay. So, you just never know what they might throw at you. And then just like Elisabeth said at the beginning, I would say right now, if you're considering a group contract, the landscape is a little bit different than it was when we joined. At that time, really, this was pretty much the only alternative we could find to fee-for-service, which just was not satisfying for us for a variety of reasons. But there is a lot of talk about a new funding model coming in 2023. So I guess I would just say, you may want to find out what that is before committing yourself. We do feel like we have a 6-month, a notice that we can give. So, but it is a lot of upfront work, as Erin said, to go into it, to pay your lawyer, to create your governance agreement. And so if there might be something else coming, I don't know if you might want to wait. And I think that's it.
I have a question about vacation and time commitment. So do you have to commit to work full time, or can you decide, okay, I want in this contract, I will be working 3 days or 4 days per week? And then the vacation time, how many weeks do you get in the contract? How long in advance you have to request the time, things like that?
I can take a stab and then others can sort of join. So there is no vacation time in the contract, but you sign on as a group, right? So that's sort of something you can decide in your own group, how you're going to manage that. You do make a commitment in the contract that patients will have access to you. I think ours says 9 to 5, Monday to Friday, excluding weekends and stat holidays or something like that. So you do have to work to try to make sure that if you're away, your patients have coverage, but there's no limitation, on how much vacation you can take. If you can find a locum or coverage, which is still the problem, then you can take as much vacation as you want.
And I think what I would add to that, I agree with Lisa, is that there's nothing that restricts it. I mean, so long as you're working the number of hours you've committed to, and just so you know, if you just divided up a year with what they've said for the 1680 hours for a full-time position, it actually comes out only to 35 hours a week. Now, that does not include, it's Christmas and holidays, but if you think about it, like that's just a ridiculously low number of hours that you would need to commit to as if that's for a full-time equivalent. So I mean, if you can find, you can actually take a lot of time because you're still going to make the hours that you've committed to. And within your group of 3 or 4, you can choose to cross cover if that's what you want to do, so that you could be away for a week or 2 weeks, and your colleagues are at least just going to provide access. So if patients need to come in urgently and things, but if you can find a locum, you can also take as much time off as you want. And then again, you can be deciding, are they going to be locuming under fee-for-service or under contract hours? So we found it advantageous. So there's no built-in vacation pay, but we found we were able to take more time off this year than any other year because we were getting a certain amount coming in and we were making our minimum hours, which doesn't actually, you don't have to commit a minimum hours per week or per month. It's actually just cumulative over the year. And I think the only restriction is you can't work more than 90 hours in a 2-week period, so that they're trying to make it that you can't like I don't know, work half-time, crazy amounts of hours and then be gone for 2 weeks of every month.
And the 1680, thanks, Erin and Lisa, the 1618 is actually based on 35 hours per week for 48 weeks. So there's 4 weeks of non-pay in the 1680. Yeah, that's a standard number used.
Okay,
yeah.
sorry.
Yeah. So I just saw a question coming in from Danielle. Do you still have your own patient panel, or are all of the patients combined for the practice in the group?
Yeah, that's an excellent question. I can answer that. We do have patients attached individually to us as a physician. We are still their MRP. It's actually billed attached to our practitioner number. It's just that it also is linked to our group payee number. So the ministry can tell that that patient is part of our contract group, but their attachment is linked to the individual practitioner. And they can pull that up. And actually, we just got our year run report. And when they run that, they break us down per physician, how many patients are in our panel, and then they do an adjustment for complexity. And that depends on how you've been billing your ICD-9 codes. And so you can definitely see who's in your panel, and they are still your panel. They're just linked to your group contract.
Thanks, Chris.
Hi, thanks for everyone's time and presentation today. I have a bit of a general question about not just this contract, but any future contracts, which it sounds like there's going to be all this new stuff coming down the pipe. It sounds like they're all happening outside of the PMA, right? And so I'm curious what implications that might have in the future, where you're signing on to an agreement. And I know in other jurisdictions, people have had different experiences where they'll start out with a contract, and then over the years, the requirements change. The time requirements might change. The panel size requirements might change. We also now need you to do X, Y, or Z. Basically, that control piece is kind of lost. And over time, and again, I don't know how much truth there is to this, but in the UK or other places, there's a feeling that they've been squeezed kind of more and more over the years. And especially if it's outside of any kind of collective bargaining type of situation, negotiations. I'm wondering how Doctors of BC kind of sees how that might roll out in the future. And it's just one of my kind of general concerns with all of this. That sounds good now, kind of, but I worry about the future.
For sure. So I want to clarify. So the changes that we're talking about, those are the changes in the payment model, like the big, robust, sweeping changes, that's going to be within the PMA. What we're talking about with outside the PMA, those are the stabilization funding, that 118 million that was given. That was what was negotiated outside of the PMA. Right now, our negotiations team is working towards delivering a new payment model a conversation that usually takes like over a year and 6 to 8 weeks to launch. So these contracts meet the PMA. So these contracts are within the PMA, which is why the Ministry of Health can release them. They don't violate the PMA, but we're looking at creating a new payment model, and it might not be a group. Maybe you can go on to one of these contracts as a single person, like the new to practice contract. I haven't seen what that looks like, but I just want to reiterate that whatever change is going to happen is going to be kind of put into a permanent, protected collective bargaining structure, and not just like a one-off.
Diana.
Are you allowed to mix it with fee per service? Like, for instance, if I commit to 20 hours per week of contract and I want to combine it with fee per service, can I do that?
So you can do that, except not with your patient panel, not with the patients that you usually see. And that's one of the barriers to entry in a rural community, especially because there's small people. So if you're working in the ER and it's your patient, it gets complicated there. But yes, you can still bill WorkSafe, ICBC. You can bill fee for service in your maternity care, but they can't be a part of your group or your patient panel. It just prevents you from double dipping in any way, is the idea.
And I would just add to that as well, like Elisabeth says, and you could also still be doing walk-in clinic work where you're billing fee for service, but it would be tricky if you saw some of your own patients. Then I'm not actually quite sure what that situation would be. But if you were seeing random other walk-in patients, you could certainly still be billing fee for service. That could be, you could have half a job that's on contract and half a job that's a fee for service clinic elsewhere.
And one of the questions that Danielle asks, because we are still a community that the hospital is run by our family physicians. So if you see your patient in the hospital or in long-term care, how does that work?
I think long-term care is excluded. So one of the things is right from the start, if you have patients in long-term care, they're not attached on your patient panel. You can still bill fee for service for anything that you're doing, but you're not including those hours under contract. I'm not sure about the hospital visit time because we are not looking after people in hospital.
Yeah, my understanding is that that is not included, like that you would still bill your fee for service for inpatient, just because it wouldn't be fair. Like, for only some doctors are providing inpatient care. So I'm pretty sure that's excluded. Yeah.
And I know it was excluded for the new to practice contracts. So yeah, so that's probably fairly similar. I have a few more questions, but I'm just looking at the screen to see if any other people have their hands up or if there are any other questions before I dive into some.
I did see in the chat, it said, can you include the time you have to take with reporting and other contract paperwork in your hours worked? So yeah, you can, so you can count that as admin time. You just can't count it as clinical time, but I mean, that's administrative time that you're working. So you pick a different category. It's sort of vague whether it counts toward your hours or not, but you can bill it.
So one of the things that have come up in different discussions is the fear that physicians will see less patients and are less available because they are on contract, which actually then plays into more unattached patients. So can you speak to that, like the amount of patients you're currently seeing compared to when you were on a fee for service?
I can start and then Erin can add too. I mean, my practice has stayed stable. Like I haven't fired patients because I went on contract, but I also haven't taken on a whole bunch of new patients because I went on contract. I actually think it increases my capacity myself being on contract because I do a lot more, say, I might do a fax prescription refill, for the patient without needing to contact them, or I might, deliver care in a different way. And so for my MOA, she has said that she actually thinks it's sort of increased patient access. So that's my thought. Erin, what do you think?
Yeah, I would say similarly. It hasn't changed for sure the number of people I see in a day. I actually probably do fit in more, especially because I can delegate a bit more. I might look at a lab work, and previously I might have said, oh, book a visit, because I thought, well, I need to get paid for sorting out that low B12 and faxing in a prescription and telling them to go on oral. But now I'll just ask the MOA to call and do all of that. And the MOA can still bill a phone code. It's like a $0 billing, but they can bill it to show that something's been done. But that took me 30 seconds. I didn't try to track the patient down. I didn't ask them to book a visit for that. And even like prescription refills, it's not like I don't like doing them without seeing the patient, but there's a lot of times where something does need to be renewed and I don't need to see them. So in 2 or 3 minutes, I can review their chart, decide that that's reasonable, fax it in. And then sometimes I'll ask my MOA to just remind them, oh, they need to get the TSH done, but I've no longer generated time to need to have a visit for that, which I think has really improved things. I feel like I can get a lot more done without actually needing to make sure that I physically that I touch base with the patient because I need to bill for it. I have a really big practice for being part-time. I have a full-time patient panel. And so for me, I'm still run off my feet from morning to night whenever I'm in the office, but I feel like I'm probably accomplishing more. And then it just helps when I see people and I stack up 3 things that need to be done for that one person in the visit, and then I'm doing that after hours. I just no longer feel the same upset about how little time I could bill for that encounter. So I don't think we're seeing less. There's a few times I will book knowing somebody needs more time, but I mean, realistically, if you've got a busy practice and you're trying to provide care, you just keep trying to do things as efficiently as possible because you need to get everybody seen.
Thanks. Can you speak to, there's a question also in the chat, what your ratio is for admin paperwork time compared to direct patient care?
For me, I would say it's no different than what you guys are probably doing. The actual small amount of extra administrative time to just do the shift coding and encounter coding is just a few minutes a day. There's more behind the scenes administrative work, especially for us, because we were pretty early with this whole contract process. I think that I probably did, it doesn't really change how much time I spend doing my patient care in a day, and then my several hours of charting referrals and all that stuff. I could probably look at my hours and give you an estimate, but I'm going to guess maybe 70-30, but I don't think it's really much different than what I was doing before. I don't know what Lisa thinks.
Yeah, I think the same. Like the thing is, we were doing, and we still do, a lot of indirect patient care, I guess I'll call it, because it's, you know, where you're charting and you're doing other things. And so, yeah, I would agree. It's somewhere probably, honestly, 60-40, 70-30, somewhere like that. I mean, which I think speaks to the fact that I never felt like fee-for-service recognized that the fact that that was part of my job, like to do all that indirect patient care, like it's just a necessary part of the job. So that hasn't really gone up or down, but I feel much better about it. Like I don't feel as resentful about it because I know that that's part of my job. And so I can plan my hours accordingly. I don't have to fit the patient in to get paid.
Yeah, I was going to say that the reason I asked that question is because I think I would estimate that most of us are doing like a 60-40 or 50-50. Like I probably spend the same amount of time post-patient care and follow-ups and labs and consults. It's about the same amount of hours probably as I do seeing patients in the office. And I was wondering if, you know, in reality, when you started tracking that, if that was sort of what you were finding. And I think that's, you know, one advantage of this is that then finally that gets compensated or counted as part of your hours.
Yeah, I really think so. Yeah. And it's funny when we have to do this clinic stabilized fund application or whatever, and then it says you can only count your like direct patient care hours. I'm kind of like, like, you know, you just don't have a good understanding of our work. Like indirect patient care, whatever you want to call it, is actually really a big part of our job. Yeah.
And I think one of the things people are very interested about is as well, compared to when you worked fee for service and now you are on contract, how does the pay compare? Is it like fairly similar, or you feel it's like increasing or reducing?
I can start with that one, but we can't give you an idea because it'll depend how much you're allotted for your full-time equivalents and stuff, but definitely an increase for me, like trying to work fee for service in with part-time hours, but a huge practice. There was just so much after hours stuff and indirect care to look after people that I can't really estimate how much, but it's been quite a large increase for what I would make for earnings.
Yeah, I would say the same. I've never really found a way to practice fee for service that's very financially viable. And so for me, it was an increase, which was really honestly like one of the main draws and part of the reason, you know, that we were interested. So I have found financially it's an improvement, but it really depends on where you are now. For someone like in our office, we've got, you know, some people that do bill very well on fee for service, and sort of, especially if you're billing, you know, more than $295 or, you know, whatever the contract band is, then that starts to become probably less of a financial thing, and probably better for someone like me who bills a lot less than that. Yeah.
Thanks. Another question that came up was, you described a bit how the process was, like all the steps you had to take and how long it took for you to sign the contract. And you also refer to, like, you know, the EMR has to be changed and all these things. So how long would you say it took for you, you know, from, okay, you got the contract to really feel like, okay, now we had the hang of it? Like how long is that process to really get used to that new way of working?
I hope it would be simpler for people who are doing it now, because as we were the first one in Vancouver Coastal, so it was brand new for the health authority. They didn't know what they were doing. They didn't know who to talk to at the ministry. Nobody could tell us what a group governance was. We felt like we were inventing everything. And even when we started doing this, if we had questions, all of our billings went into the wrong place in the first month that we were doing it. We didn't have the right group pay number. Like, there was just a whole series of things. So we spent an incredible amount of time trying to sort that out. And I'd say it was probably 2 or 3 months in that we were like, okay, I think things are getting submitted correctly and we've got the right group pay number. It didn't take long from the day-to-day hang of it, especially because your billing is so much simpler. You're not spending a lot of time going like, oh, how can I get the most out of that long patient visit? Yeah, and then the other thing is you do quarterly reports. So I would say it was at least our first quarter before we kind of got any feedback about how things were looking and getting the attachment rolling and starting to see how our hours were adding up. I'd probably say after the first quarter, and then definitely after 2 quarters, we felt like things were going a bit more smoothly, and we knew that we were on track. That was the other thing. We sort of had this worry: are we actually working enough hours? Are they getting the hours? Are they going to know that we've done the work? So that's been helpful. But we will say one of the challenges, even as we finish our first year, we still have a lot of unknowns. We haven't been given anything in writing to tell us, yes, this is how much you're going to be increasing to. Our first monthly payment in year 2 was the same as we'd been getting before, with no confirmation that it was going up. So you do feel like there's a bit of a black box of the ministry, and not being able to have a contact there has been a very frustrating part. Any question we had to be rerouted through VCH, who might not have understood what we asked. And then we just really wished the whole time that somebody at the ministry was our point person. And when we had questions about what we were supposed to do, we could just get a direct answer.
So you are recording quite a lot, and that can feel as well that you're a micromanager. And that's what I got the impression from you, Elisa, right? That you feel like, oh, that's what they don't trust that we're working. Is there any feedback about, that people say, like, after they receive your quarterly report and say, why are you doing so much paperwork? Or why are you like, anything like that?
So far, we haven't really had anything. We just got an email this week saying whatever, something, 3 hours was not entered properly, so you have not been paid for this time. So I think they're just starting to comb it. Do you know what they're just starting to look at it, because initially it did take almost 6 months to get our data. But now that they're rolling on it, we can get our data much more quickly, and it's much more effectively provided. But now that we're at the end of the first year, this is the first time they're really combing our spreadsheet. So we'll see. We have a meeting with them next week to see if they have, any other, comments for us. They say they just need to make sure we've met the hours requirement or something like that, which because we can see our numbers, we are pretty sure we have, but there's still always that little bit of uncertainty, what are they going to say? Yeah.
One of the things that questions that came up, is if you are in a group contract, and I think you talked a little bit about it, but do you find it harder, easier, or the same to find locums?
Okay, I'm going to say easier. I don't know if we've had just a lucky year. So, that's also possible, because we had a lovely resident that worked with us with training that's been available to do locums. But the benefit is we can generally offer them a bit of a better split. Or we can offer them, for those that really prefer to work like on an hourly basis, we can offer them that option. And I find a lot of the new grads. Like I noticed actually in our very short locum list that someone's name says only contract groups, you know, or something like that. So I think it's been better. I don't know if we've just been lucky, you know, for other reasons, but I think it's been better.
I'll just keep going because I don't see any hand raised, so I'm just going over my list. You mentioned that in your larger group, there was another group now that is on a group contract. They just saw the benefits from you and then they thought that's a good plan, or how did that happen? How did that occur?
I think they were interested from the start as well. They just took a little bit longer trying to figure out the FTE equivalent they were being offered and how they were going to divide that up between them. And then there was a little bit of somebody was going to go into it and then decided not to. So that held them up a little bit. So I think they were just a bit slower to get rolling. Their EOI, I think, came out around the same time. And I think they just kind of stalled and then got back on it to get everything done. And it helped because we'd gone through the process. So we were able to give them more hints about like, okay, this is what we did for a group governance agreement. And they were like, oh, okay, that's what it's all about. So that helped. But they were interested right from the start. But I think that they did see that we liked the model. We found, well, we liked the funding. I'm not sure that we liked the model of the reporting model and everything, but the funding was making a big difference for us. They have similar practices to ours where, you know, part-time physicians looking after a lot of patients, doing a lot of out of hours work just to look after your patient panel.
Great. I think you answered all the other questions. There were some questions around how it is to work with multidisciplinary teams. But I think you've touched base on that a little bit, that it makes it a bit more flexible to collaborate with other people. Anything else you feel that our physicians need to know?
I think I want to say that because I was hesitant about moving forward with tonight because I'm like, oh, well, like, oh, what's going to come? I thought that by now there would be something, but I still think that there is benefit in hearing your Erin and Lisa's experience because the experiences of the physicians and the billing that they've done, this guinea pig group, kind of helps inform whatever the solution is. And it's kind of good to know what the pain points are going into. Even if it's a different solution, it's going to not be it's going to be expanded upon fee for service. So I still feel like there's value in having this conversation. So thank you for having us.
Mm-hmm. Yeah, Lisa?
The only other thing I was going to say is something that Erin highlighted at the beginning. I do think it's really important with your group, you know, that you have trust, because it was a little bit of a jump for all of us. Like we used to get our own income, you know what I mean? We're very independent. We were responsible for our own stuff. And to have your income come in as a group and then have to decide how you're going to allocate it out, you know, it takes sort of having some trust, and especially at the beginning when we weren't getting our data and stuff. It's easier now that we're sort of a year into it, where we sort of have consistent and comparable data. But at the beginning, it was a little bit, we were all like, we had all sorts of complicated formulas, and, you know, we're trying to like calculate, you know, how much each person would get, and then what one group member does could impact the rest of the group in terms of numbers and stuff. So just to say that that's just sort of, it's a really important component to keep in mind, not just like we need 3 people, like take any 3 people. You really want those 3 people to be comfortable with each other and have good trust and stuff. And also you're sharing patients, right? You're not really sharing patients, but your coverage. You've signed up as a group to provide coverage for the panel's patients.
Mm-hmm. Thanks. Erin, any last thoughts?
No, I guess what I would say is I hope that what we're going to see coming is a blend of this, because there are some really good features and there's some really great parts. I just, it's cumbersome. And the being paid as a group is, you know, if it came out that it was going to be for individuals based on their panel and didn't require all this reporting, but that it could still be based on our encounters and our shift code, I think there's some really good aspects to this. So I hope to see some good things coming in the near future.
Great. Well, then if I don't see any more hands for questions, oh, Diana, go for it.
What information do they ask you when you do the expression of interest?
I think they just basically ask for your MSP number and then they pull your fee for service billing.
It wasn't very much. It was pretty quick. I think you just had to say who it was that you were going to be planning to go in with the group. And yeah, they did it all behind the scenes.
Great. Any other questions? No, so a few people already had to sign off, but I really want to thank you for your time, and for those already still on the call. Our next webinar will be October 11th, and we will have STEPS, which is a community health center, and we will have Shoreline Medical Society to present about their model. Both are not-for-profits, have a slightly different way of working. And again, we have the executive director then, and then we have 1 or 2 docs from each clinic to talk about their experience. They are fee for service, but they do operate a bit different. So thank you very much. Wishing everybody a lovely time. And as I mentioned, this is recorded, so we will make it available if you want to review something. And as always, if you have any questions for Elisabeth or for Erin or Lisa, I can probably pass them on. So don't be shy in reaching out if you have any more questions. Okay. Thank you. Have a lovely rest of your evening.
And
Bye.
thanks for piloting all of this and being the pioneers. Much appreciated.
Thank you.
Thanks.
Good night.